So we have moved in this meeting from discussing problems to discussing ways of talking about our problems, and then we are now getting towards the end, and it's time to start to talk a little bit about the solutions and see what we can actually do. And we are going to do this in a slightly different manner than before. We're going to have a couple of presentations to start with from CDC and from WHO. And then we're going to have an excellent panel of people who's going to give you a lot of advice on how to move forward in this very tricky area of health equity, where there's many things that can be said about that. So I hope we have Denise on board.
Yes, I'm here.
Denise from the US CDC.
Yes.
Working with health equity and intervention strategies. We are incredibly happy to have you here, and please, your presentation would come online.
So I want to start saying it's an honor for me to join this meeting, and sorry that I couldn't join in person, especially when I hear that dinner was very good and productive. In my next 10 minutes, I want to share with you how we at CDC are addressing the challenge of health equity. And so I want to start really showing to you how we define health equity. That is the state in which everyone has a fair and just opportunity to have their highest level of health. And what is also very important is the definition of health equity science. That is the science that investigates the underlying contributors to the health inequity. And really is the base for policies, surveillance, practices, and programs to really move towards elimination than rather documentation of inequities. And for us, it's a very important principle. There are several strategies to advance health equity. And but I think that what is important to highlight is the first one is to really understand how differences in access affect communities, and to develop approaches that are very targeted and tailored to address those differences. We, as I said earlier, is not just having the science, but it's really connecting the science with policies and practices, and really work together to really change the community dynamics to support the equity and also and sustain that approach. So COVID really highlighted how critical it is for us to address health equity, promote health equity in order to really promote health in our countries. And so Dr. Walensky, the CDC director, like a year and a half ago, announced and embraced racism as a public health issue, and really challenge all the CDC programs to address and promote health equity. It's really easy to say than to do. So in order to be concrete in how the CDC programs have to address that, it was an agency-wide strategy that really to integrate promotion of health equity into everything we do, to really with the vision of all people have the opportunity to attain the highest level of health possible. So we call this principles core. C for cultivating comprehensive health equity science. O to optimize interventions. R for reinforcing and expanding robust partnerships, that is extremely critical. And E to enhance the capacity and also the workforce engagement. So it's not just how we promote health equity with the communities we work with, but also how we promote that among our workforce is extremely critical. And to be more specific, we define health equity science key principles for CDC programs. So all the CDC programs had to provide specific goals that they want to achieve in the next few years to address health equity in the specific diseases or populations that they work on. And but we really just had to also define the principles for the science, that is conducting the science to lead to an action, not just to document the problem. I think we have enough data to document. We need science for action. We need to emphasize the drivers of inequity, not just the markers. We need to clarify when and how to use race and ethnicity as a way to as a marker. And what is very, very important is to promote the visibility of groups that may not be represented. Is always the groups at their footnote, because they don't even have enough, or don't have enough information to know what is going on with them. And for that, we need to use appropriate measures, because we sometimes, not sometimes, most of the time, we don't have the data and that can help us. And we also don't have the right metrics that can help us to really do this science for action. And very, very important is to really incorporate the understanding that contributes to the health inequity. So it's working with the communities that are being impacted. So not only CDC is embracing that, and it's really something that we all are taking very seriously, not just for our global work, but also for our domestic work in the United States. The federal government, we have what we call healthy people. That is like goals, national goals that we update every 10 years, and it's based on science. So all the goals for healthy people in the United States have to address health equity indicators. And when you see here, it's really a connection between economy, education, health and healthcare, neighborhood and built environment, and social and community context. So it's very challenging, because different groups do different things, but the fact that we all being called to really act on this is making us work together to really address that. Globally, we have several programs at CDC. I'm just highlighting few programs that you're very familiar with, because many of them we work together. So PEPFAR, polio eradication, malaria, global health security. But what I want to highlight is in most of the programs, we together with partners really target specific populations that have this specific need. But we also need to remember that we cannot just address that disease. We need to also address other determinants of the health that that population faces. So I'll just use an example of PEPFAR, that now we are focusing on teenager girls as an important group to target for HIV prevention and treatment. But those are also the population, those teenage girls also that have a highest rate of violence. So it's how we start addressing those issues together. Same thing for malaria, that is the it's not just having the nets, it's when we think about the vaccine with specific groups that we cannot reach. And how can we really partner in a way that we'll have that additional action that can make a big difference and sustain. So we have 6 principles that we're using for our global health work at CDC. The first one is to prioritize the needs of the most disadvantaged and or disproportionately affected groups. The second is to engage the affected populations, because more than anybody, those are the ones who know what they face. Very, very important to collaborate with external partners, including the non-traditional and local partners. We bring a little piece That is the surveillance, the science, some of the actions. But if we don't work with partners, can really make those things happen, I think it's almost impossible to have an impact. Very critical to cultivate ethical and knowledgeable staff, implement good and ethical public health practice, is a base for everything, and also confirm that the program, the principles of human rights, and confirm the program is effective, that we're really addressing that. And I want to finalize just saying that it's data, it's science, policy, practices, and communication. And when we talk about communication, it's beyond just translating recommendations. It's really considering who we're talking to, what are the principles, the beliefs, everything that the groups have. And they are very different. And we need to really address, and that's the critical part of really working with the communities. But not only with the groups we want to have impact, our workforce is critical for us to also consider our workforce. We are a diverse group, and a diverse group with different skills, different principles, and we need to continue to promote a diverse group, because diverse brings creativity. And so it's not just, as I said, looking at who we want to have an impact in the health, but also the ones that we are working with to achieve that goal. So just few documents that we have on our website. And I do think it's an amazing opportunity for us to really work and be concrete in what we can do to really make a difference in promoting health equity everywhere in a sustainable way. So I want to thank again, and I'm looking forward for the, sorry that I put this, I'm looking forward for our discussions.
Thank you very much. I really like how you've been able to structure a very difficult field in such a nice manner, and how you really point out how important it is to work together with these communities. We have maybe one or two questions from the audience before we move on.
Thank you very much. My name is Roma Chilengi from Zambia. And thank you for breaking down what I think is a very difficult topic, and I think organizing the thoughts so clearly. I have one troubling question. Whose responsibility is it to ensure there is health equity?
I think it's a very important question you were raising. And I think we're all responsible for that. And what I see at CDC, since I'm representing CDC, the director feels responsible and accountable, but she's also calling all the program directors responsible and accountable. In my role, I have to make sure that all my programs are addressing that. And what's very important is, before we would address and say, oh, we're doing this project. No, it's how everything we do has to address that. And being responsible and accountable means we have to talk about that all the time. And we have to give concrete examples. I see with my programs, I have to give concrete examples of what we mean by that. And we only know examples when we talk with people who are affected. So I think all the leaders have to be accountable and responsible, but leaders in all the different levels. And because we need to lead and moving forward, and only doing and showing that we really believe that is a way to do it.
Thanks. Maybe one more question. I hope you can stay on, because we're going to have a question and answer period also later on, and I'm sure there's going to come back questions where we want.
Yes, I'm staying on.
Thank you very much. So then we can move on to our next presentation. Dr. Rüdiger Kretch, are you with us?
Yes, I am. Hello, Anders.
From the WHO and the Department for Promotion. And as we already heard, health promotion is a really very important part of health equity, and not least how we tailor health promotion to really address health equity. So I hope you can give us some more thoughts around that and how WHO works in this area.
Yeah, thank you. Thank you very much, Anders, for that kind introduction. And first of all, also, let me say how much I enjoyed, Denise, your presentation, because what you said is exactly what we need to do, and where we also see that it works in terms of looking at the underlying factors of inequities, but also at the same time, what are the triggers? What are the measures that we know work very well? And colleagues, it's always a bit difficult to step into a hybrid meeting, because indeed you had ongoing discussions about the problems that we're facing in global health and in public health. So I'm sure that you mentioned already that in the first year of the COVID pandemic, global prevalence of anxiety and depression increased by a massive 25%. One major explanation of that increase is the unprecedented stress caused by social isolation resulting from the pandemic. And linked to this were constraints on people's ability to work, to seek support from loved ones, and engage in their communities. Now, this is exactly, we've been shown, with the hard way, I would say, during the COVID crisis, to number one, see what makes us healthy, but also to see what happens if health is not in all policies. And in IANPHI, colleagues, friends, we've talked a lot and about what we're doing on social determinants of health, and now we've been seeing that these inequities really matter even more so during a crisis. So within all this, I think what shows us what drives disease, like for instance, the anxiety, the increased anxiety and the stress that was caused by social isolation, also shows us what is actually promoting better health. So let us come to that in just 1 second. But I think that this, therefore, is while a pandemic is, of course, a disaster, but we can draw some lessons from it for the future as well. So in terms of health promotion, what we can see from this pandemic also is that people gained weight, they drank more, and those who smoke consumed more, while about 700 million smokers want to quit. While people first in the pandemic were more physically active, activity levels went down the longer the pandemic lasts. And then low adherence rates with some of the measures, that is staggering, and also low adherence rates for vaccination in many countries. So that, as such, describes a little bit where health promotion can assist in the future. So, for instance, we have 35 years of experience in how we engage with the community, so that any campaign, any health promotion campaign can only be successful if you're engaging the community you serve, so the addressee, into your campaign. Co-design is one of the core features of health promotion. So you're not doing something for somebody, but you're doing this with the population group you want to address. So just imagine that we would have used those experiences from health promotion when actually deciding on the public health measures during the pandemic. where, very often there was a global, from WHO, from us, or the national public health measure, which had to be implemented at the most local community. And for the future, I would advise that, we're doing frameworks at global or national level, but we need to adapt those at the most local level. So in the schools, in the restaurants, with the hairdressers, and with the public transport systems, so that we're applying also a population-based approach where we see what is this population group, what is it, what are the risks for this specific population group in this local community. And we're applying a framework of public health measures where we know that we need to adapt those to the local situation. So as I said, we've learned it the hard way. In NCDs, for instance, people were not treated or were treated much too late. Many people were diagnosed too late and didn't receive the services they needed. So this gives us a second lesson for universal health coverage, for resilient health systems, and for the role that health promotion needs to play within that. Health promotion means to enable people to take control over their health. So very clearly, people with NCDs, that didn't happen. This control is compromised by the multiple crises we face: environment, social, economic, health, hate and fake news in the net, social disruptions, staggering levels of inequities. So what is WHO therefore proposing we all do? Number one, we clearly see that health is created in decisions in other sectors. So the role of public health is to not only advocate for those other sectors to consider the potential health effects of what they're doing, but also to radically change the way we are creating our societies. So we have been talking about resilient health systems after Ebola and of course now after COVID, but actually what we need is resilient societies. And that starts with a value and respect of the planet Earth and its ecosystems. And that means that we need to much more focus on planetary health, including enhancing pandemic preparedness and improving health and equity, and to do this with the instruments of health promotion that I just outlined. Secondly, we need to design an equitable economy that serves human development within planetary and local ecological boundaries. And that means that we need to look at the economies, whether or not they are promoting the values that we stand for of equity, of social inclusion, and human rights. So there is a whole area of work to look at well-being economies, where from the health perspective, we can contribute a lot in terms of what well-being economies could do to reduce harm through enforcing accountability and regulation systems. Thirdly, we need to develop healthy public policies for the common good. That means that we're assessing the potential health impacts of policies in different sectors much more consistently and coherently before actually those decisions are taken. And fourthly, we need to achieve universal health coverage. That is, of course, central to social protection for all and social and societal stability. we need to address the impacts of digital transformation. That means while technological transitions and innovation can create new opportunities for connection, health literacy and knowledge sharing, and more effective, efficient service provision, some features of digital systems and digital exclusion can, however, create isolation and exacerbate inequity. And we need to be in touch with those industries that drive this innovation, this technological transformation from a health perspective. So these were just the 5 action areas of the Geneva Charter for Wellbeing that has become a top priority for the World Health Organization. And as I think you all said before, it's not enough to again wait until we have a next pandemic, but to address the root causes that might trigger the next pandemic at the same time. And with this, I hand over back to you, Anders. Thank you so much.
Remember, we need to stand up from the clap so we get some health promotion in the room. Thank you very much. That was also very inspiring and also nice structured. We shouldn't forget the people that are online. And we have a question here from Mexico, Juan Rivera, about COVID-19. We have equity between people and between individuals, but of course we also have equity between countries. And he is asking how do we implement a global governance for health equity among countries, thinking about how the vaccine distribution actually failed this time to achieve that.
Absolutely key. As we saw at the start of the pandemic, we saw a lot of solidarity. You saw heads of government coming together, sharing information very, very quickly. Just remember how fast information was shared this time in terms of the occurrence of the virus in different countries, but also the information that was shared in the production of mRNA vaccines at the start. And then you saw how solidarity failed when national interests came into play. And that cannot happen again. This was unwise because it killed so many more people, and it just enlarged the gravity of the pandemic. So how do we address this in the future? As you know, there's discussions underway about a treaty, a contract for pandemic preparedness and response, where actually this solidarity plays a key role. And we will see what member states in the end will be able to agree upon. But actually, we need to come to the understanding that it's in all our interests, in our national interests as well, to actually have a solidarity approach, an approach that looks at the inequities between countries as well as within countries. We need to prioritize the support to the most vulnerable people, because that will help us to get over a crisis much more rapidly than not. And that is a learning we need to get out from this pandemic, because, mind you all, the next pandemic, which we will face, if not the root causes are addressed, will be more harmful, more severe than COVID-19 is or has been. So as you know, we have the Disease X program, where we have identified possible vectors, possible chains, virus chains that could lead to a next pandemic. And if you look at how they could come into the world, there's a lot of causes, upstream causes that could trigger a next pandemic. So if that is not done, we need to prepare now to be more resilient in responding to the next pandemic. And again, I think health promotion can offer its services there much more forcefully than it has done in the past.
Can I offer one comment?
Please.
Think what was said about COVID vaccination is so important for us to learn. Also wanted to highlight the importance of the routine vaccination. We have millions of kids with 0 vaccines. And we need to really, I think what COVID has shown is if we don't address all these issues where they're happening, it becomes a problem, an issue for everybody. So even when you think about polio and measles, it's like huge needs, not just to have the vaccines, but to work together to address the barriers of vaccination, because it's something that now we are facing. That is, even when we have vaccines, many times the programs cannot deliver or people don't want to receive. So how together we address all this with, for example, the vaccines for children, including polio and measles, because I don't think we need, like it was said, I don't think we need to wait for another pandemic, and we need to really learn from what happened and be more proactive. Over.
Thank you. Any questions online or in the room? Please.
Very nice to hear from global public health institutions and the perspective on addressing health. Question is, if you reflect back before the pandemic of COVID, the last 20, 30 years has seen the largest investment in financing into global health. But it has not, do you think it has, how do we address this problem of the pandemic of catastrophic expenditure to lack of essential primary health care? So that's one question. So after all this investment, we have not been able to address this pandemic of catastrophic expenses. Then the other biggest pandemic which we have, in spite of a lot of discussions on it, we are still not able to address non-communicable diseases, diabetes, cardiovascular diseases, cancer. So there's been huge investments on immunization through Gavi, in malaria, TB, and HIV through Global Fund, and now we have new funds being created. But malaria in Africa has, in fact, gone backwards. And immunization programs, which used to be the starship of primary health care and global WHO, has gone backward. So let's be careful we don't hide behind COVID too much and go beyond the Stockholm syndrome of COVID.
Thank you.
Yeah.
Do you want to comment on that?
Of course, and thank you very much for that question. Now, first of all, yes, you're right that funding for global health initiatives has increased, but we also have to understand that overall health is the biggest industry in so many countries, and which then also requires a much more astute global health action. So in a globalized world, you have so many risks otherwise, and by not spending on global health, we see what happens then. I think we're at 9 trillion now at the costs of this COVID pandemic. And again, as I said, the next one could be even worse. So the money on global health is well spent. Now, secondly, you're absolutely right with, did we make a gain on reducing out-of-pocket spending and especially catastrophic expenditure? And here, I mean, we know the what, we know the how, it is a political choice. And we at WHO work, of course, with governments to actually make universal health coverage a reality in all countries. Now, what you have seen over the last 10 years was that there was an increase. So we actually were well on track with achieving the 2030 target on universal health coverage. There was a good start, let's say, but then there was a sort of decrease. So once political agendas changed and a pandemic came in, we saw that actually countries who were on a good progress were actually falling behind, and especially with people who are more vulnerable. So the out-of-pocket spending has increased, especially for those people, and that is a no-go. Because again, it's in all our interest to actually have universal health coverage, because that's the only way how we can deal with the next pandemic to come. So people need to understand that the weakest link in a chain globally will actually address whether or not we're going to see a next crisis. And thank you also for your third question on NCDs. I couldn't agree more with you. People with NCDs have also fallen behind during this pandemic. And indeed, we have, while this is 72% of all deaths is NCDs, we are not paying attention as much as we need to this specific population group of people with chronic diseases. And that requires a much better linkage with the health systems. And of course, 68% of all these are preventable. Tobacco, alcohol, physical inactivity, and bad nutrition, sugar, too many fats, salt. So if you're addressing, and air pollution. So if you're addressing these 5 big risk factors more comprehensively, I'm in WHO leading those risk factors on tobacco, alcohol, and physical inactivity. And my colleague next door is doing the nutrition and food safety, and Maria Nera, another colleague, is doing the air pollution part. So with these 5 risk factors, we could prevent so much disease and free up the resources in the health systems that we need for actually those diseases that we are now struggling with in terms of epidemics, pandemics, but also demographic trends. So it is in all our interest to step up the work on NCDs much, much more forcefully and address the commercial interests that are behind those 5 risk factors that I just mentioned. And to, of course, name a spade, the tobacco industry is killing 8 million people every year. And it should not happen that, this industry is still making so much profits, which they individualize, and they socialize the costs, which are extremely high, with, billions and billions of dollars and strains on the health systems.
Thank you. Denise, you have any comment?
You mentioned, yes, I think your point is so critical. And the way I see is that the COVID pandemic has really highlighted that we need to think not just by disease. We need to think about people. We need to think about communities. We need to think about systems, because you saw that a risk factor for death was non-communicable diseases, and also no access to whatever precautions we had. And so they also show that the systems we have are not resilient. Just vaccination. It's not just the systems are not working, people now don't want to be vaccinated. So it really showed that we need to change a little bit our approach. When I think about people with HIV, they're taking treatments as part of PEPFAR. Many of them have diabetes, hypertension, other problems. Yes. So we need to really use that as an opportunity to really focus on the people. and on the communities. I know it's hard because most of the time the funding is by disease, but I think
Yes.
we really need to change how we think and how we work together, because just one group will not be able to address that. But I think together, looking at, like you said, the focus in what is didn't work and what is not working right now. And the way I see is a call for action. I think if we miss the opportunity right now, it'll be very, very hard to really have effective programs to address everything you said.
So thank you
Couldn't
very
agree
much
more.
to both of you. Let's give them an applause. Okay, thank you very much. I hope you both can stay online because we have going to have a question and answer period towards the end too. I'm sure you can both contribute to that. I would like to ask my co-moderator Trygve to come up here and help me taking care of the rest of this. So if you the next picture, please. We just would like to give you, I mean, since we're all in epidemiology, we love figures. So this is just to show how inequity also exists in the Nordic countries. And maybe Trygve, you can give us an explanation about this one, since it's in Norwegian.
No, I guess that's why I was invited to be Anders' sidekick. You know, we compete in the very egalitarian Nordic countries to be the very most egalitarian country. And Norway, of course, we think we are. But look at this, right? We here obviously have years along the x-axis and expected life at the age of 35 at the y-axis, men and women. And then the different colors is the different levels of education. So you have primary school is the red one, upper secondary the blue one, and university or university college the green one. And this we thought we would include just as a backdrop for optimism, but also for pessimism, right? Because optimism, fantastic improvement for all these groups. Pessimism, because even in this extremely egalitarian context, how stubborn the social inequalities have been.
Next picture, please. And so, and I could show you exactly the same graph from Sweden. Actually, we even getting even worse because the differences are getting bigger over time. And this is what then happens during a pandemic. You can see people with background in different countries in Sweden. Sweden is becoming a fairly heterogeneous country. Actually, 25% of population have a background outside of Sweden somewhere. And as you can see in many parts of the globe. But you can also see how the COVID hit these different communities so incredibly different. Risk of getting admitted in green, and even risk in death. And you can see that it's 5, 6, 7-fold more risky for people with background in other countries. And of course, this is not a genetic or anything like that. This is very much socio-economy and the way different groups in our society live. And it's reflected also here very much when we get into a pandemic situation. And the next one, please.
Yeah, should I take that one? And I should also say we could show the same, what Anders shown, the same pattern we saw in Norway. But this is the last image. And of course, what we see is, this is not to show you, obviously, the representative or big picture of equity, even in Norway. This is just a small slice of the inequality, obviously. But we brought this in because this is the analysis we actually did yesterday. And what we see here is vaccine uptake for those 3, that's the blue one, and those 4 is the orange or red one. And what you hardly see, but it's primary school to the left, and then upper secondary, and then university or university college is the third one from the left. And this is coverage then among everyone, not only those that have recommended the vaccine. And why is this somewhat interesting for us? This is because we see here again the gradient, but also we use it now to discuss a very concrete policy, because this is a pattern we see with free vaccines for everyone. And the discussion right now is to start getting co-pays, right? So even in Norway, we have then this debate: what will now happen with especially the group with primary school education, if we on top of this start to take co-pays? And of course, what's not shown here is that probably in that group we have more of the risk factor, the groups with the risk factors than in others, but that's not shown here either. Sorry, Trygve, can you take a step back and talk into the microphone? Okay, but I was done, so I hope at least you saw the message. The basic point was simply we see even here a gradient, right? And now it's a debate in Norway whether we should start having co-pays for vaccines.
So this is mainly just to show that the results of health equity and different ways that we really need to address them. So we're going to start by inviting our panel coming up one by one. Markku, do you want to come up? Markku is the head of the Finnish Public Health Agency with a background in many different agencies when it comes to public health and socio-economic background. So we just give you a couple of minutes to say a little bit about the situation in Finland and what you think about the presentations we had so far.
Thank you, Anders and Trygve, and good afternoon, everyone. Third Nordic country now here with the agility came, but thanks for these presentations. When we think about the situation in Finland in these terms, so we can say that the health of all groups, socioeconomic or educational background, in these groups, the health of public has developed positively in recent decades, but there are still large differences between groups, and wide inequalities persist between socioeconomic groups, for example, by education, as was shown here, occupational status and income, and also different domains of health, such as self-reported health, morbidity and mortality. And the aim to reduce these inequalities, it has been at the heart of the Finnish health policy for the past 30 years. And just 2 weeks back, the most recent parliamentary working group for reducing inequalities in health was established. So very persistent political problem, but also it has been in the political agenda for a long time. But the results then. Our legislation obliges the promotion of people's health and welfare and the realization of equality in the quality and availability of services also. However, so far the differences have not been significantly reduced, and in some respects these differences have been even increasing. And we at our institution, THL, we have thought that in order to reduce the growth of health inequalities, effective tools need to be developed to reduce the large health inequalities, and these effective tools needs to be developed comprehensively with a community approach. It's not just public health agencies or healthcare which can deal with the problem. And one thing is that we need a regularly updated monitoring data on the state of health inequalities, which will then guide actions to reduce these inequalities and assess the impact of these actions. So making these differences visible to support the consideration of health inequalities in different sectors of society nationally, but also regionally within country. And then enable anticipation of changes and evaluation of the effectiveness of these activities. Thanks.
Thank you.
Thank you, Markku. And then I have the pleasure to introduce up here someone not from the Nordic countries, Dr. Mesay Hailu, the director of the Ethiopian Public Health Institute.
Thank you very much. Good afternoon, everybody. I would like to say a few points about Ethiopian context in terms of health outcome, health service utilization, and health outcomes in terms of morbidity and mortality attributed to infectious diseases and non-communicable diseases. So we often do this disaggregated analysis by socio-demographic status, place of residence, like urban and rural areas. As everybody knows, majority of Ethiopian population is rural, living rural areas, and just living in persistent agriculture. And some of the people are also living in hard-to-reach areas with poor access to basic infrastructures of health and other services. So when we do such disaggregated analysis, we see disparities between regions, geographic areas, place of residence, and even we, in Ethiopian Public Health Institute, we have the National Data Management and Analytics Center. So we do, in collaboration with the Washington University, we did the burden of subnational burden of diseases. So we see the market differences and the trend, actually the gap is a little bit reducing. Still we have huge differences, disparities. So in cognizant of this fact, the government is doing to address this inequality, health inequalities in health and in different socioeconomic indicators based on the scientific evidence that is generated by Ethiopian Public Health Institute as well as the Central Statistical Agency. So we do have the ministerial level executive committee meeting and see such evidence from different sectors and try to involve different sectors. As you know, equity, all the social determinants of health disparities or health outcome disparities are out of the health sector. Most of them are related to this social and economic sectors. So the involvement of other sectors are of paramount importance. So we are doing this together, and the other policy initiative by the Minister of Health is addressing this underprivileged populations and areas. And there is a special department at the Ministry of Health that do disaggregated analysis and just providing tailored interventions in order to fill the gaps or that disparities. So at the Ethiopian Public Health Institute also we have the health systems research department, which often do research on the building blocks of the health, and we generate evidence based on that scientific evidence. We often create awareness and push the policymakers and other sectors to address the inequity issues and to fill gaps. Still, equity, investing in equity is, as you know, it's investing in socio-economic development. It's not burden. So actually, the major document of the national plan, as well as the Ministry of Health Sector Transformation Plan, addresses this equity as the prime, the number one agenda in addressing health issues. So we are doing this, but still we have disparities, as I said, in health outcomes by different socio-economic status. Thank you.
Thank you very much. And then we are coming back to Europe. And welcome to Dr. Fernando de Almeida from Portugal, with a wide background in public health and education. And we already shown, I think, from Norway how important education is when we talk about equity. So please.
Thank you. Good afternoon, everyone. First of all, I would like to thank you for invitation of this round table and greet our colleagues of Parliament. And let me share the grateful and pleased because Lisboa, Portugal will host the Network Europe Spring meeting in 1993. I have to share this because we are very, very happy. So, about the questions and about the presentations we had, let me share something not quite, but different, little different. We know that presently there are significant, urgent, and common challenges to address by the public health institutes worldwide. Besides the pandemic, there are the increase of mental health crisis, aging population, for example, energy limitations, raises of inequalities due to pandemic and Ukraine war, including the difficulties faced by displaced people, migrants, and so on, climate change, and are just a few examples. If the pandemic by itself imposed devastating effects on vulnerable populations, we cannot underestimate the additional significant consequence on health and well-being from all these situations across the planet. Thus, a shift from no frameworks to new paradigms of operation are urgently needed. Public health institutions have also the unique opportunity to set up new solutions and propose new approaches to restore unity, build cross-sectorial collaborations, constitute new networks that would ultimately lead of sustainable development goals, compliance. So, for instance, for example, what you have with the problem? Exacerbated health disparities and health inequities in the community. But you have to make action. We listen this Denise, he said, science for action. Science for action. So, we need, such as, for a more holistic approach that complements the biomedical model to address also social determinants of health. We need to shift the focus to a model of health promotion and disease prevention in primary care. We need long-term approach for foster individual health, subjective well-being, and community well-being. How can be resolved? How can be address this? Two examples. One framework, for example, is a social prescribing, and if you want, I will speak I will explain this concept. And after, as you know, the implementation of health impact assessment. This is our best proposal. Thank you.
Thank you very much. And we are so grateful that you are willing to host the next European annual meeting, Fernando. The last panelist, but not least, is Dr. Lissette Navas, who's the director of the Costa Rican Institute of Research and Training. So please, Lissette.
Hello. Buenas tardes. I'm going to speak in Spanish. Well, I will try to do it in English. Good afternoon to all. Thanks to the organizers for giving me the opportunity to be in part of this round table. I come from a small country of Central America, Costa Rica. We have a little bit more, we have more than 5 million inhabitants, and we have only 51,000 square kilometers. Sadly, Costa Rica nowadays is one of the countries in Latin America where disparity has increased the most. And the COVID pandemic worsened this situation. Poverty has increased in rural areas to 28%, and the overall country is to 22%. This is according to the last household survey on 22. Unemployment was up to 2 digits during the years of the pandemic. This year, it was on the 21 was 15%, and this is a first semester of 2022, it came down to 12%. But there is a big difference between women and men. Women has 16.5% and men 8.6%. Costa Rica has an education blackout right now. I think this is the worst problem that we have at the country. Previous the pandemic, we had a quality deterioration of the public health programs. But now has been worsened because of the absence of virtually learning in the public sector. These are some of the problems that we have, and this has been moving Costa Rica away from the accomplishment of the Sustainable Development Goals. In regards to the health sector, during the pandemic, our major problems were to decentralize diagnostic tests, the preparedness of the healthcare hospitals, of the hospital settings for critical care, and the lack of interoperability of the information system to be able to follow up the emergency and to follow up the isolation measures. For our institute, the main challenge was to increase our capacity on diagnostic tests and also to decentralize to the capacity of the test to the border provinces and to the coastal provinces. When I have to think about what we can do to approach inequalities, I don't have a doubt that health research, data analysis of the surveillance, or evaluation of the interventions are the major tools that we have to show and to document and to evidence the disparities in our countries. Also, I think that through the laboratory-based surveillance, we can prioritize some regions for a good access for a quality diagnosis through training and through quality assurance programs. I guess after this presentation, the big challenge is science for action. I guess we are used to do the research, but we don't go to the communities. We don't do the programs in the communities. Sending these results of the researchers to the communities or to the organizers or the movements or NGOs that go to the communities, it means a little bit more of advocacy work, not only with the politicians, but also with the technical people that is working on the primary care or in the communities. Thank you.
Thank you very much, Lissette, for a very powerful both description and analysis of the challenges in Costa Rica. Anders and I had prepared a lot of questions we would really like to ask the panel, but we agreed here that we should first give the opportunity to you. So please, anyone that would like to ask any of the panelists a question or a comment.
Microphone up here. Thank you.
Thank you very much for all the presenters. I just wanted to add one comment that we noticed in Jordan at the time of the COVID, when we did analysis of the mortalities and we were trying to see whether the vaccinated were dying less than the unvaccinated, we found that some of the displaced and refugees were not getting enough vaccination. And when we investigated into what was the case, we found out that they themselves do not go to get the vaccine, although the policy in Jordan was everyone should get the vaccine, regardless of whether they are refugees or displaced or non-Jordanians. So, another in-depth study was done on some of the cases, and we found out that they were running away from being vaccinated because if they go and get the vaccine, they will be located and then policies could deport them from the country. So what I'm trying to say is that the lack of coordination between policies is one of the reasons that we can we see sometimes inequality in the services that are provided, and this of course reflects on the outcomes, the health outcomes. So we have to take this seriously and consider this when we do the analysis. Thank you.
Thank you. Any comments from the panel? Markku.
Yes, thank you. This is very important and reminds me to be able to not only communicate with the other institutions and community stakeholders, but also to the public, right to the public. And of course, there are very many different kind of groups depending on ethnicity and so. And so we have to tailor the message and use non-governmental intelligence to be able to talk to them. It's of course interpretation of the message to different languages, but also it's very important to be able to use other spokespersons when we are messaging. And well, I think this is one reason why we heard yesterday by Mariken Leurs from the Netherlands, the presentation of these behavioral insights work, which is attached to this theme. I will say very in an important way.
Thank you. And before we get the next question, just want to add to that it's also very, I think, powerful, shows how important it is to have a all-of-government approach, because many decisions taken in different parts of government can have these kind of consequences, which I don't think that the people really think about. So I think that's the reason why we really need to be present in many places. Please.
Can
We have a comment online?
Yes.
Please.
I just want to first, it was very nice seeing the presentations and seeing the realities. Doesn't matter where we are, the basics are the same. And especially some specific things that Dr. Fernando said about Portugal and also the presentation about Costa Rica. What I want us to, in regards to the last question, is it's important for us to work together as different parts of the government, but it's very hard. So I think it could be a very good opportunity moving forward that the National Public Health Institutes are also a place where we can start sharing strategies from one country or one region with the other, because the more we start showing to leaders that it can work, the more, and that's what should be the goal, the more we can make it easier for many other places to move in that direction. So when I think about action, I think we just need to see really how we promote action and how we share success stories. They don't need to be huge. Even the small ones would be very important. Over.
Thank you very much. And then please, we have a question here, the floor.
Yes, hello. I'm Teresa Tam. I'm the Chief Public Health Officer of Canada. And I think there was a question about who's responsible and then what's the best strategy to instill an equity at the core of everything that we do. And I was going to ask our speaker from the CDC as well. You have a Chief Health Equity Officer. In the Public Health Agency, we have a specific office that is health equity focused. But during the pandemic, I believe there's a specific health equity strategy. So in your IMS, or the way that you manage your emergency, someone has to be looking at the health equity aspects of your response the whole time. That's the responsibility of that desk. And how do you think that has been helpful? And is it something that we should be building, of course, into our health emergency preparedness and response?
Thank you for the question. I think the point is we need to be reminded to really look at this issue all the time. And having an office, not just at CDC-OD, but also in most of the divisions now, has been very, very important. Also having, like you said, the presence of a group doing the IAM as part of the IAM structure was critical. We knew about the issues with health inequities, but having somebody a group that would not just highlight how we are addressing, but also bringing experts to really see how we could do that. It's not just experts on data, but the connection with the communities, like many of you have said. So for us, in order to really have an impact, we feel we need to have the presence of people who will really be pushing us to move forward in all different places. So I think having somebody doing the IAM structure is very, very important, and we continue to have that for also other responses. Over.
Thank you. Any more questions or from our participants online? Any? Okay.
Sorry, it's Teresa Tam again. I do have a second, part B. It's about instilling health equity, and one policy that we have in Canada is called SGBA plus, and gender-based analysis plus, meaning the plus is the intersectionality with race, ethnicity, religion, age, disabilities, for example, and that is an actual requirement on all programs, on our guidelines that we put out. So if we put out a guidelines on public health measures, it has to go through a SGBA plus lens, or you don't publish it. And I think having that in every department, mandatory learning opportunity for every staff, has made us instill equity in a systemic way. So I don't know if other people have experiences in that, and research too. You must have an SGBA plus lens when you are putting out research applications, if you're a research funding organization.
Actually, we have a similar thing in Sweden, coming from the government level actually, but also implemented at the agency level. As soon as we start a project, you always have to have this aspect on board to be able to handle it.
We also have at CDC, audit projects have to really show how they're addressing health equity. And like in Canada, also who we fund, also they have to address that. So it's embedded in everything, in guidelines and everything. Is there a way that we can really make this be part of our priorities and our goals, like it was asked before, whose responsibility is, and we need to integrate and make that the default. Over.
If I may,
Yeah,
Anders?
Rüdiger.
Yeah, we have this, of course, in WHO as well. But what I just wanted to say is, by having this co-signature, it's not just a clearance, but it's a co-signature of our colleagues looking at these aspects, gender equity rights, actually increases the accountability of each of us who want then to publish or to have a project, because it's no longer just possible to just tick the box administratively, but you need to explain what you mean. And we have a monthly call with colleagues from this team looking at gender equity and rights, to review what we have said. And that is a sort of internal capacity building as well for each of us to be much more serious about mainstreaming this into our policies. And as you were talking about, accountability, I think that is an administrative tool and instruments that helps us to be more accountable for the things we do.
Thank you. Taj from Africa CDC. So I think for us at the Africa CDC, one of the greatest lessons we learned from the COVID-19 pandemic is the issue of equity. Let me put it that way. And I think the COVID-19 pandemic actually exposed the systemic inequity that's been in the global health space. Take, for instance, the essential countermeasures, at the outset. I think the WHO colleague did talked about that at length, and one of the ways the African Union tried to address that, especially the head of states and the government of the continent, was to set up a digital pool procurement platform, to ensure that member states are able to access those essential security commodities, irrespective of the ability to, to finance those commodities. So now going forward, I think it's for us to take those lessons, and use them in order for us to build back better and stronger, that does not seem to be happening the way we had envisaged. So let me give you two good examples. Today, we have the epidemic fund. It has been put in place. Quite a lot of member states, I don't know in the global, but from the global perspective, quite a lot of them do not really understand what exactly this epidemic fund is all about. How should they assess that in case they need to, you know? But yet, a lot of discussion is going on, you know, in some quarters. Number two, the global health security governance itself, I mean the HR and all those things, is also ongoing. From the COVID-19 pandemic, we know that the regional mechanism played significant role, you know, in terms of responding to the COVID-19 pandemic. But today, most of the regional mechanisms are not part of the discussion of this global health security, discussion. That's the review of the HR. So what we see is that the global mechanisms are in discussion with the state mechanisms. So in between, that gap, you know, is not being adequately addressed. So what that simply means is that when you have certain diseases that are of regional, but of not global significance, you know, it falls through the crack. So it means that it has to get to certain quarters of the world, you know, or certain member states before such outbreak will be flagged, you know, in such a way that we mobilize the necessary resources. So I think going forward, we've learned a lot, but I'm not sure we are putting most of what we have learned, you know, into structuring how do we come out of the pandemic, but much more importantly, build back better and stronger going forward. Thank you.
Thank you very much. I see if we have any questions. Otherwise, we're getting close to the end of this session. I wonder if our panelists have any reflections to share. It is a very difficult area, but extremely important. And I think sometimes our role is very much to show that there is a problem, because the solution is very often outside the sort of immediate area of public health. And as many of you have already pointed out, it's very much about economy. That when people have money, housing, work, and so on, a lot of these problems goes away. And of course, that's not always something public health can do something about, which doesn't mean that public health cannot really point out that there is a problem. And I think that's what we very much talked about, how we, in an effective way, actually can show our governments that they have a problem and that they really need to think about it when they start doing different things in many different areas, not least education. So once again, thanks a lot to our panel and to our presenters, and not least to you, who even in a Friday afternoon after lunch managed to be very much awake and working together with us. So thank you very much.